Becca Broyles, co-owner and educator of the Coding Corner Medical Coding Education. Today, I would like to talk about Ortho Coding Unlocked, mastering accuracy, anatomy, and audit-proof documentation. The learning objectives for this session are to strengthen understanding of orthopedic CPT structure, apply NCCI bundling rules accurately, interpret documentation for arthroscopy versus open procedures, correctly apply modifiers, work through some ortho case examples, and improve compliance and reduce audit risk. Orthopedic coding is high volume, high risk, and highly technical. We want to focus on precision, especially around arthroscopy, fractures, and joint procedures. Why ortho coding is complex. An open procedure refers to a type of surgery where a large incision is made to directly access and visualize the area being treated, allowing for comprehensive intervention. A percutaneous procedure is a minimally invasive medical technique performed through a small puncture in the skin, allowing access to internal structures without large surgical incisions. Arthroscopy is a procedure that uses a fiber optic camera to diagnose and treat joint problems. A surgeon inserts a narrow tube attached to a fiber optic video camera through a small incision about the size of a buttonhole. The view inside the joint is transmitted to a high-definition video monitor. So you could have multiple procedures, or there could be multiple approaches in orthopedics: the open, percutaneous, or arthroscopic. Bundling rules vary by joint. Implants and devices must be documented. Laterality is essential, and many procedures involve multiple compartments or structures. Orthocoding requires coders to think anatomically. The same joint can have multiple compartments, and the approach determines the code family. Documentation must be crystal clear. An orthoanatomy refresher, coding relevant. The knee has the medial, lateral, patellofemoral compartments. The shoulder has the glenohumeral joint, subacromial space, rotor cuff, and labrum. The hip, the femoral head or neck, acetabulum, and the labrum. The spine, cervical, thoracic, lumbar, facet joints, and nerve roots. Coders must visualize anatomy to understand what the surgeon actually did. For example, knee arthroscopy codes depend on which compartment was treated. Arthroscopy coding fundamentals. Arthroscopy coding is one of the most audited areas. Coders must know which services are included and which are separately reportable. Arthroscopy codes are per joint, not per structure. Debridement or shaving is often bundled. Meniscectomy overrides chondroplasty. Add-on codes apply only when allowed by CPT. And NCCI edits heavily restrict combinations. Diagnostic arthroscopy is only billable if no surgical procedures performed. Remember that chondroplasty is bundled when performed in the same compartment as a meniscectomy. A meniscectomy is a surgery to remove a torn meniscus and can be done partially or totally. while a chondroplasty is a minimally invasive surgical procedure used to repair and smooth damaged cartilage in a joint, most commonly the knees. A synovectomy is a surgical procedure that involves the removal or reduction of the synovial membrane, which lines certain joints, such as the knee, shoulder, or elbow. Here you will see the code families for the knee arthroscopy. 29870 for diagnostic, 29881 for a partial, medial, or lateral meniscectomy, 29880 for a medial and lateral meniscectomy, 29877 for the chondroplasty, 29882 or 29883 for meniscal repair, 29875 for a limited synovectomy, and 29876 for a synovectomy of major or two or more compartments. Some knee arthroscopy examples: medial meniscectomy plus a chondroplasty of the same compartment in the knee. You would use CPT code 29881 only. The chondroplasty is bundled. Medial meniscectomy plus a lateral meniscectomy would be the CPT code 29881 because it was both the medial and lateral meniscectomies. Major synovectomy plus meniscectomy. CPT 29876 if the synovectomy was in two or more compartments and documented, and 29881 if allowed per NCCI edits. Debridement is the medical process of removing dead, damaged, or infective tissue from a wound to promote healing and prevent infection. 29822 and 29823 are for shoulder debridement. The 29822 is for limited, and the 29823 is for an extensive debridement. Code 29824 is for a distal clavicle excision or Mumford procedure. The Mumford procedure, also known as distal clavicle excision, is a surgical intervention aimed at alleviating shoulder pain caused by acromioclavicular joint issues. 29826 or subacromial decompression or SAD is a surgical procedure aimed at relieving shoulder impingement by increasing the space under the acromion, allowing for better movement of the rotator cuff tendons. 29827 is rotator cuff repair. Rotator cuff repair surgery is a procedure aimed at repairing damaged rotator cuff tendons, which are crucial for shoulder joint motion. 29806 is for capsuloropathy. Capsuloropathy is a surgical procedure aimed at repairing and tightening the shoulder capsule to stabilize the joint, particularly in cases of shoulder instability. 29807 is for slap repair. This is a surgical procedure to fix a slap tear, which is an injury to the superior part of the shoulder labrum, often caused by trauma or repetitive overhead activities. The SAD code, or 29826, is an add-on code and cannot be billed alone. And debridement is often bundled when performed with repairs. Some shoulder arthroscopy examples: rotator cuff repair plus SAD. The CPT code would be 29827 and 29826, which is the add-on code. Slap repair plus debridement. You would only code the CPT code 29807 because debridement is bundled into the slap repair. Mumford and SAD. CPT codes 29824 and 29826. Fracture coding essentials. Fracture care codes represent the entire episode of care, not just the procedure. Coders must understand whether manipulation occurred. Fracture care includes the global period. You have closed versus open treatment, manipulation versus no manipulation, internal fixation versus external fixation, and laterality is required. Documentation requirements say the fracture type, displacement, manipulation, and fixation method should be documented. Some fracture coding examples: closed treatment with no manipulation for a distal radius fracture, CPT code 25600. Closed treatment with manipulation would be CPT code 25605. Open reduction internal fixation, or ORIF, would be CPT code 25607 for extra-articular, or CPT code 25608 or 25609 for intra-articular 2 or 3 fragments. Joint procedures open. Common ASC open ortho procedures. Carpal tunnel release, 64721. This is the surgical procedure to relieve pressure on the median nerve in the wrist, often performed as open or endoscopic surgery. Trigger finger release, 26055. This is also known as stenosing tenosynovitis. This procedure restores smooth movement by releasing the tendon sheath. Bunionectomy, 28296 or 28299. This is removal of the bunion on the foot caused by bumps, often performed to relieve pain. This is removal of the bump on the foot caused by bunions, often performed to relieve pain and improve foot function. Achilles tendon repair, 27650. This is surgical repair of the Achilles tendon to treat injuries or conditions affecting foot movement. Implants must be documented, and remember, laterality is essential. Open procedures often seem simple but require careful attention to documentation, especially for bunion procedures. Open procedure examples: carpal tunnel release, CPT code 64721. Trigger finger release, CPT code 26055. Bunionectomy with osteotomy, CPT code 28296. Some common payer issues are missing laterality, missing implant documentation, and confusion between bunionectomy code families. Modifier use in ortho coding. RT-LT are required for all paired structures. 50 is for the bilateral procedures. 59 or XS is distinct procedural services. 22 is increased procedural services, and this must be justified. The modifier 22 requires detailed documentation of increased complexity. Simply stating difficult dissection is not enough. And then 51 for multiple procedures. Ortho documentation pitfalls. Missing compartment details in the knee especially. Unclear technique, arthroscopy versus open. Missing laterality. No description of manipulation for fractures. And missing implant details. Query proactively. Poor documentation can lead to denials or incorrect coding. Right knee arthroscopy, partial medial meniscectomy, chondroplasty of the patella, and limited synovectomy. The correct coding would be CPT 29881, which is the meniscectomy code. The chondroplasty and synovectomy are bundled. Shoulder arthroscopy, slap repair plus the SAD are CPT codes 29807 and 29826. Distal radius, ORIF, CPT code 25607 for extra-articular. And bilateral carpal tunnel release, CPT code 64721 with a modifier 50. Some key takeaways. Ortho coding requires strong anatomical understanding. Arthroscopy bundling rules are critical. Documentation must support approach, compartments, and complexity. Modifiers must be applied correctly, and query when documentation is unclear. Orthopedic coding is high stakes and requires both clinical insight and technical precision. Thank you for joining us today. Please visit us at www.thecodingcornermce.com.